Hello and welcome to Echo Ontario Skin and Wound. I'm Dr. Gary Sibold, a dermatologist internist with an interest in wound care and education. Renika.
Hello, good afternoon and welcome. I'm Renika, I'm the project manager.
Okay, and Tamara.
Hey everyone, I'm Tamara and I'm a research coordinator. And also, we do have our social media presence. So as always, you can follow us on LinkedIn, Instagram, or Facebook at Wikipedia.
David.
Hi, my name is David Walker. I'm the clinical coordinator for Project Echo Ontario Skin and Wound. If you have any cases, just send me an email and I'll help you put them together.
David at woundpedia.com. And Linda.
Hi, I'm Linda. I'm the Project Echo Administrative Assistant. May I ask everybody to please sign in to the chat with your full name, your profession, and where you're from. Also sign your colleagues in if you have any of them joining you. Thank you for your participation in the survey last week. The winner of the Echo gift card is Beverly Rochon. If you're on Beverly, you'll have a card coming to you. And can I ask everybody to please take the time out to do the survey? And thank you.
Okay, Andrew.
It should be up. Anyway, hi everybody. My name is Andrew Mohan. I'm the multimedia coordinator for Project Echo. For the territorial acknowledgement, we acknowledge that the land from which we're presenting is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, the Chippewa and the Wendat peoples, and there's not many diverse First Nations, Inuit, and Métis peoples.
I'll let them know, Kaylin, and them know because she plays in.
And by doing so, give our respect to our first inhabitants. Also, I just want to remind people to keep their microphones mute unless you are being asked to speak. So, that's it.
Okay, Dr. Zhao.
Hi, my name is Sacheng Zhao. I'm a family doctor in Mississauga. I do wound care as well as long-term care and then obviously family medicine.
Okay, let's go to Kingston.
Hi, Karen Smith here. I'm a rehabilitation physician here at Providence Care Hospital and Queen's University.
And hi, I'm Jolene Heil. I'm a clinical nurse specialist for wound care and an NSWAC at Providence Care and Queen's University.
Dale.
Hi, ladies and germs. My name is Dale Kalina Samji. I am an infectious disease physician in Brantford and Paris at Brant Community Healthcare System, and I'm joining you from Brantford today. I do infectious diseases and wound care and digital health, where I'm also the Chief Medical Information Officer here.
Jeremy.
Hey everybody, Jeremy Call here, or should I say Dr. Jeremy Call? Just kidding. I was feeling left out last time Pat got that label. No, I'm a nurse advisor for First Nation Inuit Home and Community Care, and I'm an advanced practice nurse in NSWAC, and I live and work in Sioux Lookout, which is on the unceded traditional territory of the Ojibwe people of Lac Seul First Nation, signatory to Treaty 3. Thank you and welcome.
Okay. Have I left anybody out? I don't think so. Linda, are you on?
I am.
Okay, introduce yourself.
So I'm Linda Norton. I'm an occupational therapist. I put all of my various credentials in the chat for you, but I am on faculty with IIWCC. I'm on faculty with the Moon Masters program at Western University, and then I'm also the Director of Learning and Clinical Education for Motion, and best practice author of the Wounds Canada Best Practice Guidelines for Pressure Injuries.
Okay, and you are front and center for today's interactive didactic session.
Awesome, thank you. I'm going to share my screen. So I have some slides for you. I have pictures of equipment, and surrounded on the floor around me is other equipment that I will show you as I go through. And hopefully if you hear any crashing or that, it's nothing other than my office kind of being destroyed, but that's part of the fun. So we started with a poll question before we even get into the objectives. So Andrew, if I can get you to pull up the polling question, that would be great. And the question is, what therapeutic support surface should be used for a client at risk of developing a pressure injury? A reactive non-powered foam support surface, an active powered alternating air surface, an active powered alternating air surface with low air loss, a reactive non-powered air support surface, a reactive power low air loss surface, or a convertible hybrid surface can be either active or reactive with the addition of a pump or through the settings on the pump. What do you think? There's lots of choices. Now, as you're answering, I like to equate therapeutic support surfaces to dressings in some ways because what you put on the wound is incredibly important, and there's a ton of different categories. And I think people forget how many different options there are when it comes to therapeutic support surfaces. And quite literally, there are a cajillion different support surfaces out there, and it's up to us to make the best decision that we can make. All right. We've got about 64% who have participated. Is that a high enough score for you, Gary, or would you like a few more?
It's just fine.
Okay, then let's share the results. So we have a real smattering of answers. Most people are answering the convertible or hybrid surface. And it's interesting that hybrid surfaces are being promoted out there. But to give you the highlight of the whole presentation, there's actually no evidence that one support surface is better than any other. So we need to start thinking about some of the other issues and concerns that are most appropriate for that individual patient. Okay, so let's talk about the objectives that we're going to cover today. We're going to talk about assessing and managing pressure management properties of all surfaces. So thinking about bed, footwear, chair, wheelchair, commode, and car seat. We're going to assess the client's positioning in the wheelchair to identify any red flags. We're going to evaluate the impact of various devices on pressure, friction, and shear. We're going to identify the features and functions of support surfaces and their potential impact on the client. We're going to evaluate and optimize transfers for pressure management and to reduce shear forces. We're going to discuss the feasibility and sustainability of some of the pressure management plans. And then we're going to talk about some special situations as well. So the quote that I always go back to when I think about this area of practice actually comes from the spinal cord best practice guidelines. And that's really looking at this quote. Many people with spinal cord injuries perceive a trade-off between performing pressure redistributing activities and participating in life. Everything takes longer to accomplish for a person with a spinal cord injury, and many feel they simply do not have time for both. Participating in life is the choice that they often make. It doesn't matter what setting you're in, whether it's long-term care, the community, rehab settings, clients still have activities that they want to participate in and do. You may have therapeutic treatments that need to happen, and the surface you select may help to facilitate some of those things or limit the client's opportunities, and it's something we really need to pay attention to. Now, my understanding is you have already been through some of the fundamentals with Dr. Karen Smith and Jolene, looking at pressure, friction, and shear, but I want to remind you of those as we start to look at equipment and how to implement that. So the first one is pressure. So what I want you to do is take your hand, put it flat on the table or surface in front of you, take your other hand, make it into a pinky finger, and drive it into the back of your hand. You can't tolerate a lot of pressure because it's over a small single point. If you spread out your hand and press down, then you can tolerate more pressure because it's over a wider surface area. Most of the equipment and the devices that are available to prevent and manage pressure injuries work on this principle of trying to distribute that pressure. The second thing we need to think about is shear. And shear is defined as the force per unit area exerted parallel to the plane of interest. That doesn't really say anything clinically. What we're talking about is if you move the skin on the back of your hand, what's happening on the inside between the bones and the skin, that shearing force, right? But it's also what's happening within the tissue. So if you notice the way my hand wrinkles as you start to press the skin up towards my fingers, what's actually happening on the inside is the structures are changing relationship to each other. And that shearing force is an incredibly destructive force, tends to double the impact of pressure. So when I went to school, we used to talk about reduce the pressure, reduce the pressure, reduce the pressure. Now we're recognizing that we need to reduce pressure, yes, but even more importantly, we need to think about reducing shearing forces. Then the last thing to think about is friction. And I always get in trouble when I talk about friction in relationship to pressure injuries because some of my pressure injury colleagues get upset because friction doesn't cause pressure injuries. And that is true. But if you think about it, friction is this force and it's the resistance to motion, right, between my two surfaces of my hands, and it will generate heat. It's the friction between my fingers and the back of my hand that allows me to move my skin, which is what creates the shearing force. So clinically, we often reduce shear by reducing friction. So let me give you a practical example. Some of you may find in clients' closets, you have these repositioning sheets, right? And they were designed often and promoted as a way of reducing staff effort when it came to repositioning clients, right? You slip them under the client, the sheet moves on itself, and then you can move the client easily. But here's the thing, it also reduces friction. So you could potentially use these sheets to reduce friction, which would reduce shear. Usually the way that we do that is when we're thinking about repositioning or moving the client in bed. Putting these repositioning sheets underneath is a great way to help to reduce that friction and then reduce the shear. If I think about it from a practical way, when we start to think about seating, I said that most cushions work on this principle of distributing pressure, and it does it in two ways. The first way is through contour. So if you look at my skeleton sitting on that particular cushion, you can see that there's a divot or a well for those ischial tuberosities to sit in. So it's pre-contoured to help to distribute that pressure. And then there's a couple of leg troughs on the front, again, to help you distribute pressure. What that means, though, is the cushion always has to be in the right way. And you can't tell looking at just a label on the cushion. Of course, I've got to show you the label, right? You can't tell kind of where the cushion needs to be because the cushion may be on backwards. What you need to do is you need to feel for that lump that's in the center of the cushion. And if you can feel that lump, that should be at the front because that's meant to separate the legs, right? So there's a leg trough on each side. The other way that you can distribute pressure is looking at air or foam. The idea is that the client will sink into that material and that material will distribute around that person's hand or around that person's body and distribute the pressure on all areas. In order for air cushions to work, though, you have to set them up correctly. So my recommendation is to work with your manufacturer or vendor partners to get some experience inflating cushions. But the idea is if there is this iso flap on the front that you see on the top left-hand picture, you have to push the green side in before you put air in the cushion. Otherwise, air will just go into the one front section. Then you pump up the cushions so it crests. Then you sit the client on the cushion and you put your hand under the client to feel how much space is between the client and the bottom of the wheelchair. So the idea is the person should be floating in the cushion, not sinking through the cushion. Okay, so you can actually, I'm going to pull this up. You can actually stick your hand in, and if your fingers come down right to the base of the wheelchair, then that has too little air. If your client is sitting on top of the cushion and not sinking into it, it's too much air. They always have talked about developing a gauge to try and make that easier, but they found that the clinician's hand check like that is actually more accurate than anything else they've been able to come up with. I want to show you one other cushion, and it's the only cushion I'm going to mention by name. And the simple reason is it's the only cushion out there that works on this principle. There is one cushion called the Ride Designs cushion that operates on a pressure offloading principle. So rather than distributing pressure, this works like an orthotic and it takes the pressure away from the ischial tuberosity so there's no pressure on those areas and puts them at the posterior thigh and posterior pelvis. The issue with that is that the client has to be positioned exactly the same way every single time they're up in the wheelchair because it works like an orthotic. Think about if you have an orthotic in your shoes and the orthotic is just off slightly, you know how much it hurts your feet, right? Same thing. If the cushion is off slightly, it will cause more pressure to different areas of the client. Also, you cannot use that cushion on any other surface. So the wheelchair and the cushion were designed together. If you put that cushion on a different surface, it might not work. It also is a little bit challenging for those of you who start to look at how much pressure is in different areas. So if you look at the pressure map on the right-hand side, you'll see higher areas of pressure as indicated by the red at the back of the pelvis and at the back of the thigh. The white area in the middle at the bottom is where those ischial tuberosities are. So that's good. And we have increased the pressure on those other areas. But the question is, are we going to get breakdown there or not? And really, the only way that you are going to know whether or not this cushion is going to be appropriate in those areas is to do a skin check and look for skin changes that might be related to pressure. Okay, so what do we know for sure? Well, shear doubles the impact of pressure. Our tolerance for pressure decreases over time, and I can prove that to you. If you think about sitting in a workshop or at a movie or wherever you go, the longer you sit, the more you shift your weight, right? And that's because really the interstitial fluid is moving away from the areas of pressure and really causing your bony prominence to become more bony. So the idea is we want to reposition people frequently enough to help that interstitial fluid from moving away from the areas of pressure. Other things that we know for sure is the seated buttocks soft tissue anatomy influences the risk of pressure injury development. We know that asymmetrical wound undermining is related to shear, and that's the force that's in play. We know that 82% of people with pressure injuries who have a mobility disability have those pressure injuries in the area of the pelvis. That's really important because when we look at prevalence studies and incidence studies, you'll often see the heels noted as the highest area that's impacted. But if you have somebody who has a mobility disability, then you really need to be thinking about the pelvis as an area that you're monitoring. And then there's certain diagnoses that are more associated with pressure injuries as well. When it comes to assessment, this is really a multifaceted area to start to figure out what's going to be most appropriate for your client. So you have to think about how mobile your client is. Can they weight shift themselves? Where is the wound? And is it being caused by any of the equipment that they have? I used to get referrals all the time that said, this person has a wound, therefore you got to change their mattress. Well, the wound might not have been coming from the mattress. The client might not be lying on that area on the mattress. So the mattress might not be the problem. You've got to be a detective. You've got to think about the wound characteristics, where it is, what shape is it, is there any undermining? And then you need to think about all surfaces on which the client sits and lies. That could be a commode, that could be a easy chair, that could be their bed, a wheelchair. It could be another device as well. So you've got to be thinking about all of the different devices that might be in play for that client. And so we do have knowledge that undermining that goes all the way around the wound is usually caused by an impact injury. So there was some kind of injury, an impact, the fluid built up, separated the layers of skin. When that skin opened up, the fluid leaked out, and that caused your undermining. When you get undermining like you see on the left-hand side, that undermining is caused by shearing force. So there is good evidence for that. My clinical opinion is the direction that that undermining goes will tell you what's happening with that client. So if asymmetrical undermining is always caused by shear, that's the pathway of the bone going across the skin. So I want you to try an experiment and take your hands and put them under your bottom and find your ischial tuberosities. And then I want you to rock. I see Jolene and um, Dr. Smith playing along, and I think Dale, you might be playing along there too, so that's great. So what I want you to do is then rock back and forth, and I want you to feel those ischial tuberosities grinding away, right? So if I had a wound on my ischial tuberosities and my pelvis was moving in that way, then that's the pathway that the undermining would happen, right? So it'd be more head to toe rather than side to side. If you had undermining that went side to side, that's usually caused by lateral movement or somebody turning in bed. And then if you have asymmetrical undermining around a coccyx that goes 3/4 of the way around, that's actually caused by trying to get the client out of bed. So a caregiver has put their hand or arm under the client's legs, under the client's head, and spun them on the surface to sit them up. So what happens then is the skin does this, so it gets twisted, creating that shear force, and that creates the asymmetrical undermining. We also need to think about transfers. How often is that client transferring? What kind of assistance do they need? And it's really a good opportunity for a referral to rehab folks so that we can start to evaluate how they transfer and offer some other suggestions. We may need to increase the assistance we provide during transfers to help to decrease the pressure, friction, and shear that occur during that transfer. And we may need to really evaluate the frequency of those transfers as well. Then we need to think about all of the surfaces. So whenever you're doing a surface assessment, again, I'd strongly recommend getting an OT or a PT involved. We need to be thinking about their wheelchair and seating. We need to be thinking about their bed and mattress. If they're driving, we need to think about their car seat. And then we also need to develop some strategies around other surfaces. And the best thing we can do is educate our client about pressure, friction, and shear and how to protect their skin so that when they are in unique situations, such as, say they're visiting loved ones and have an opportunity to take a plane flight, well, what are they going to sit on in the airline seat, right? What are they going to sit on in the car? What are they going to sit on as they're engaging in some of these other activities? In some long-term care homes, they have bikes that clients can be on the front and the staff member pedal on the back. And those, again, are seats where that client is sitting. And so we need to think about what's happening there for pressure management. So let's talk about interventions. What do we know? Well, there have been some research studies done on therapeutic support surfaces. And when it comes to some of the guidance, it says that static air mattresses or overlays, alternating pressure mattresses or overlays, and gel pads may be better than foam mattresses and may cost more. And it's unclear what the best treatment is for either preventing or treating pressure ulcers, what the effects of those treatment options are on the people's comfort and quality of life, and whether or not there are any unwanted effects. Isn't that great when you look to the research and it doesn't give you a lot of really great guidance, right? So that leaves us to our clinical judgment that we really need to say, okay, what's going to make sense? So one way that you can start to evaluate the conversation of people talking to you, whether it's manufacturers or other healthcare providers, is what terminology they use. The terms pressure reduction and pressure relief are no longer used. And that's because they're based on the idea that if somebody lies on a surface and there's less than 32 millimeters of mercury pressure between the client and the surface, then it would be a pressure relief surface and it reduced the pressure, but not to that threshold, it'd be a pressure reduction mattress. Well, if I laid on a mattress and Dr. Sibbald laid on a mattress and then Jolene laid on a mattress and Dale laid on a mattress, we'd have different pressures because we carry our body weight differently and we weigh different amounts. So it makes absolutely no sense to be able to classify surfaces based on that. The other thing is that magic 32 millimeters of mercury study was done on normal male fingertips, which has nothing to do with our patient population. So we need to start describing surfaces with different characteristics. So the first thing we talk about is how much pressure distribution the surface has. We talk about how well it conforms to the client's shape, which is envelopment. We talk about how much does that client sink into the surface, that's immersion. Alternating pressure is some surfaces in some cells increasing in pressure, others decreasing in pressure, and then they alternate back and forth. Lateral rotation is when the bed surface starts to turn the patient. The challenge is when the surface starts to turn the patient, the client often slides down to one side, and then the surface tries to turn them back, and then the client slides down the other way, creating more shearing forces and may actually not be helpful for pressure injuries. Then you have low air loss, which is a feature of some support surfaces where the air comes up through the bladders of the mattress underneath the cover with an idea of evaporating moisture. Works really well if you have full body excess moisture, is not appropriate for somebody who is dehydrated or does not have a full body moisture issue. Then you can have multi-zone surfaces. That means that there's different materials in different areas of the surface. And then you can have active or reactive. So an active support surface changes pressure independent of what a client does. So alternating air might be an example of that. And then a reactive support surface changes pressure based on what the client does. So as you can imagine, if I'm lying on a foam mattress on my back, the mattress deforms to my shape. Soon as I turn onto my side, the mattress deforms to my side. The thing that we really have to be careful of when we start talking about therapeutic support surface is thinking about entrapment. As soon as we take a mattress off somebody's bed and put a new mattress on, we may be creating increased risk. Or even if we put an overlay or something that goes on top of the mattress onto the client's mattress, again, we can be increasing risk. So let me show you an example of that. So this is a powered air surface. And you can see on the side that the bladders come all the way to the edge of the sides. The idea is this particular surface will alternate, will provide that change in pressure for the client. But look what happens when the client sits on that surface. They will start to migrate out of the bed because the mattress collapses as the client gets to the edge of that bed. If you think about them lying on their side, the mattress collapses as they lie on their side, and they can get stuck between the bed rails and the mattress, or they can fall. So this particular type of mattress tends to increase the risk for your client. In fact, the RNAO guidelines took a really strong stand on this, and they reflected back to the Health Canada guidelines around entrapment that we have to follow in healthcare. A lot of the best practice guidelines miss these because the guidelines that we have to follow are actually from 2008. So they say the constant low pressure devices do not meet Health Canada's guidelines and should only be used when the support surface, when the benefit of the surface outweighs the risk of entrapment and less risky options have been considered. So the idea is that with these particular surfaces, you have to prove that they're more effective than some of the other things that are there. And that's the step that's often missed. People go directly to these powered surfaces without thinking about the other options and then needlessly increase risk. They also really take a good job of pointing out that low air loss support surfaces can be associated with dehydration risk. And so we really need to make sure that we're addressing that. I can see a comment in the chat that yes, one of our residents in long-term care on an air mattress due to a pressure injury, but the air mattress was removed and she had an increased fall from the air mattress. So definitely a consideration. I think one of the things that happens is people say they need a low air loss mattress, and what they mean is a therapeutic support surface. So this is another example of a powered air surface with alternating air. But what this one has is a foam transfer border. So you can see that foam edge on the side. The idea now is when the client sits on the mattress, they're better supported so they don't migrate out of the bed. And you can see that when the client turns onto their side, that bolster helps to keep them in the bed. So it can be a really important way of thinking about moving forward. But still, you might not necessarily need the air surface because, as I keep saying, there's no evidence that a powered surface is better than a non-powered surface. The other kind of surface you can get is one that doesn't have any air. This one happens to have foam in gel, but again, there is that transfer border to help prevent that migration from the bed. So you may be able to have just as good pressure redistribution on a surface like this and foster the client's bed mobility because they're not sinking in quite as much, but they are getting enough pressure redistribution to be able to manage that wound. So just to summarize, there's risks to all the therapeutic support surfaces. When it comes to non-powered surfaces, there's generally less risk. Soon as you move to the powered air surface, there's more risks in terms of entrapment and with immobility. Entrapment is helped certainly when it comes to having those foam bolsters. And then from the low air loss perspective, there is a risk of dehydration and there may be a risk of infection when you're transferring this equipment from one client to the other. It's not enough just to do a surface cleaning. You've got to actually clean the interior of the surface as well. So when it comes to what surface is recommended, the international guidelines recommend a pressure redistribution foam reactive full body support surface for individuals at the risk of pressure injuries. So that's the answer to our first poll question. Those of you who recommended things like the hybrid surfaces, you may be increasing the risk to your patient needlessly, as opposed to having something that is an actual just foam mattress. I see a question here. Why is dehydration more prominent with air redistribution surface? It's more prominent when there's the low air loss feature, and that's because you can't turn it off. So that air is constantly trying to evaporate moisture from the client. And if there's no moisture to evaporate, it will start to dry out the patient. That's the issue. When you start to think about why you might change the mattress, you might want to think about the overall risk of pressure injuries, the response of the skin and tissue, the posture of the client and their sleeping position, and potentially whether or not they share the bed with somebody. You want to be thinking about what the other goals of care are as well, and I'll show you a tool for that in a minute. You also want to think about the location of the wound. If the wound isn't in contact with a therapeutic support surface and is never going to be in contact with a therapeutic support surface, why do you need all the bells and whistles, right? So you want to be thinking about some other approaches first. And then you want to be thinking about, do you need wedges or other things that might be helpful for that client for repositioning? So, as I said, we've got to think about risk. Then we need to be thinking about, okay, what's the client's function? And then we need to be thinking about what pressure redistribution surface makes sense. It can be really overwhelming. So there is a free tool from Wounds Canada. It's the Therapeutic Support Surface Product Picker. You can find it on their Product Picker page. The first part is at the bottom left of this slide. So you look at how at risk your person is for pressure injuries. Then you look at how mobile they are in bed and see where those two meet. If the person already has a pressure injury, then you look at the number of pressure injuries to make that selection. When you move on to the right-hand side, you have a decision tree. And so if you got to a reactive support surface that was blue on the bottom table on the left, you start in the blue square saying reactive support surface on the table on the right. And the idea is that will guide you through some of the clinical considerations to get you to the type of surface that you want to actually have for that individual client. It does get you generic descriptions, and so you can work with your manufacturer partners to start to think about what surfaces you have and how they fit into that particular table. All right, we have your next poll question. So Andrew, if you can launch that, that would be really helpful. The question is, if your client weighs 180 pounds, approximately how much weight is going through the ischial tuberosities? You've got 10 pounds, 50 pounds, 90 pounds, 100 pounds, 125 pounds, or 150 pounds. We're only at 46%. Let's get a few more people voting. Remember, from an educational theory perspective, if you guess and get the answer wrong, you learn more. And if you guess and get the answer right, you also learn more. So guessing is totally appropriate and really important. And I'm not going to get mad if anybody has the wrong answers. We're still at 58%. If we can get a couple more, that would be great. We're at 60. Are you guys okay with that? I'm assuming. Let's release the results. So the majority of you answered between 90 and 100 pounds. The correct answer is actually 125 pounds. So when you do the math and add up all the segments of the body, it's about 125 pounds. What's important to think about is that's a lot of weight going through a small area of the body. So when you go home tonight, I want you to take your thumbs, go into the bathroom, put your bathroom scale up on the counter and start to press your thumbs into the scale. Do not try to get to 126 pounds. You will break your thumbs, okay? But just feel how much pressure that is. Your thumbs are about the same size as your ischial tuberosities, and that's why it's important to think about that, because that will help you when you're starting to think about cushions and the importance of the cushion as well. I am frozen. There we go. All right, let's look at the seating recommendations from the best practice guidelines. The first one is to recommend using a seating support surface with pressure redistribution properties for individuals at risk of pressure injuries when in a seated position. Makes total sense. Advise individuals who spend prolonged periods in a chair or wheelchair to use a pressure redistribution cushion with other seating, for example, when traveling. Well, that makes sense too. If you needed a pressure redistribution cushion when you were in a wheelchair, you need it every place else that you go. I'm going to come back to the third one in a minute. The fourth one is duration of sitting out of bed should be limited as much as possible for individuals at risk of pressure injuries who cannot reposition themselves while seated. That makes sense too. The third recommendation is it's good practice to frequently reposition at risk of pressure injuries who are seated out of bed. Teach and encourage independent chair, wheelchair users to reposition as often as possible. Makes sense. But the one that doesn't make sense is this duration of sitting out of bed should be limited as much as possible. When you actually think about what that means is if the person isn't sitting in their wheelchair, it means they're on bed rest. And although the guidelines talk about, you got to think about the whole patient position, you got to think about their goals of care, you've got to think about all of those things. Just reading that guideline that the duration of sitting should be limited is going to lead to unnecessary bed rest and complications for the patient. So just recognize whether or not bed rest is appropriate. First of all, is the area of pressure going to be higher in bed or in the wheelchair? And often it's higher in bed because the first thing the client does is they elevate the head of the bed. We got to be thinking about friction and shear and if that's going to be an issue. And often clients are sliding in bed, creating that shearing force. What's the risk for further skin breakdown? That can be an issue as well. Does the client have an appropriate wheelchair or sitting surface that they can go into? And what are the goals? So we really need to be thinking about that. We also need to recognize that bed rest is not benign. So there's a lot of other secondary complications that will happen, including things like pneumonia, anorexia, urinary tract infections, heart issues, learned helplessness, decreased executive functioning. All of those can be an issue. And as I said, if we think about sitting up in bed, if you raise the head of the bed, the client is sitting almost at straight leg. Now, if you think about it, would you sit any of your patients on the floor with their legs straight out in front of them and sitting upright? The answer is probably not, because you know their legs don't bend that way. Yet we position clients like that in bed all the time. So we probably are better off sitting somebody up in a fitted wheelchair for them. They're going to have less pressure in those areas and have much less friction and shear. We do know that if we do provide a skin protection cushion for those clients, they will have a reduced risk of pressure injuries. One of my biggest issues is those who work in acute care. If you are getting somebody in an early mobilization program, and you sit them up in the bedside chair with pillows or without pillows, you really need to be thinking about a skin protection cushion in those areas as well. So that leads us to the question about, well, what's the best cushion? Well, I can find studies that look at air cushions, that look at gel cushions, and look at offloading cushions. And the reality is, we don't know. There's no sort of definitive study in this area. They do say that what kind of wheelchair cushion performs better in terms of interface pressure management is unclear. Individual evaluation of the interface pressure is suggested for the prescription of wheelchair cushion in clinic. So really important that you think about getting your rehab professional involved. What you can look at, though, is the position and posture of your client. So if they're sitting in a posterior pelvic tilt, that often leads to the curvature of the spine. So they're more at risk of pressure on their sacrum and on the apex of their spine. And then if you have somebody that's seated with their pelvis tilted, you probably have more risk of pressure on one side of their ischial tuberosities versus the other. And if you have somebody sitting in anterior pelvic tilt, you've got more risk of pressure on the front of those ischial tuberosities. So it's important to position the client well in the wheelchair and make sure that they're positioned in the way that they were intended to be positioned. It also holds true for lower extremities. So you want to have those aligned. If you think about it, if you have a client who has adducted or having their legs come together, they're more at risk of pressure injuries between their knees. If they're abducted and those knees come away, they're more at risk from pressure on the side of those wheelchair footrest hangers or on their ankles, and their feet might not fit properly on the footrests. And I see often people try to reposition the feet, but the problem is actually coming from the pelvis and having that client's legs abducted. And then you can also have clients that are windswept where their legs are going off into one direction. And again, we really need to think about getting the footrests set up for them correctly. So getting rehab involved is important. Another thing that you can control is the foot elevation and thinking about the lower legs. First of all, you want to think about foot plate height. So if you look at the picture on the left, you can see that the foot plates are set up such that the femurs are parallel to the cushion. That will help to distribute pressure. If those foot plates are raised, then the femurs are not getting support and you're getting more pressure over those ischial tuberosities. If you have somebody who is sliding, do not elevate their legs. When you elevate their legs, it causes the muscles to pull on the client's ischial tuberosities, creating sliding. So that's one trick you can use to help to prevent the sliding. And then look at the posture of the client. If you look at the left, that client has slid down and you've got a ton of part of their leg that's not supported. But if we can get them pulled back in the chair, that might be better. And if you look at the client on the right, you see they're getting a lot of pressure through their feet because of the way that they're sitting. So a couple of tips that I want to make sure people are aware of. First thing is you want to make sure that that wheelchair belongs to that client. You want to check that the cushion is positioned correctly, and we talked about that. You want to make sure that the depth of the seating surface is not too long. If you sit somebody on a chair that has too much seating space for them, they'll just slide. You want to make sure that you're not causing somebody to slide because they can't straighten their legs and you're trying to force them to do that. And then you want to make sure that the femur is parallel to the floor. Once they're positioned, we need to be thinking about weight shifting, and that may mean tilting the wheelchair so the chair, the pressure comes off the butt and onto the client's back. We might want to teach them leaning to one side and then to the other side. And then also leaning forward is really helpful because that gets the weight off of the coccyx. What we don't really know is how much time we should be telling somebody to shift their weight. So it varies from every 10 minutes to every 2 to 3 hours in terms of what clinicians are saying. We really want to be repositioning as frequently as possible. But the question is, how likely will somebody be to reposition? Well, it depends. If they think that the pressure injury is a life-threatening illness and that performing a weight shift will help, they definitely follow through. But if they're not able to do it or there's any other negative consequences, then they're not going to do that particular issue. And then in terms of what we do in clinic, we talk about habit stacking. So if a client is already reading, for example, I'll get them to weight shift every time they finish a chapter or turn a page. If they're watching TV, I get them to weight shift every time a commercial comes on. Okay, here's your next poll question. Should the sling be removed, partly removed, or remain in place? Or does it depend on the client, or does it depend on the provider? Okay, lock in your votes quickly, please. Okay, we're at 60%. Let's end the poll and share the results. So we've got almost a tie between removed and depends on the client. I used to be in the camp of always remove the sling, always remove the sling, always remove the sling, except that that might not necessarily be the best approach. We do know that when there are lifts and slings in place, there tends to be more repositioning that happens of that individual client. We do know that the seams of the transfer devices will increase pressure, so we want to make sure that the seams are out. But I really disliked the last study, and I can say that because I'm actually one of the co-authors. But we looked at what sling material impact is on clients and the interface pressure, and we didn't find any appreciable differences between different types of sling fabric and no sling at all. So if your client is sliding on the sling, if they're uncomfortable, definitely remove it. But if they're sitting well on it, you're not having any issues and people are resistant to taking it out, it may not be the thing that you necessarily want to advocate for. So I would say it depends on the client. Last couple things I want to leave you with. This was a case study that we looked at as part of a research project. She had been seen by nursing. She had PSWs involved. She had wound care specialists involved. She had everybody involved. She had a pressure ulcer over her coccyx. She did feel uncomfortable when she was sitting in a wheelchair, which is pretty significant for her. She was a spinal cord injured client. When I came in to see her, I looked at her chair and she had a hard metal seat pan that somebody had folded up the back of. So they made a bend in it so that her cushion wouldn't go backwards. which was fine initially because the back support was in front of that lip. Over time, the relationship to that lip changed. So she was sitting directly on that sharp edge of the chair when she was in her wheelchair, and that's what the cause of the pressure injury was. She ended up having a stage 4 pressure injury. She was on bed rest for 6 months and actually passed away from a systemic infection, all because of this particular issue with her wheelchair that really should have been looked at. So the message I want you to leave you with on that case study is not to just think about the person in the wound, but really look at the wheelchair and see if anything seems out of place or what they might be sitting on that might be causing pressure. Just like you would do for looking at somebody's shoes if you're thinking about somebody who has lack of protective sensation. All of this needs to go into the plan when we start to think about the client. So we've got to think about the client and their characteristics, the equipment characteristics, what's the environment, who's going to be looking after that equipment, what occupations and activities are they doing, and then how do we make that sustainable? If anything is too complicated for the client to do or too big a change, it's not going to happen consistently. So just like for dressings, this area is complex. And I love this quote, for every complex problem, there is a solution, which is simple, innate, and wrong. Really has to be directed to that specific individuals. I'm going to open it up for questions, but want to leave you with the thought that you really need to be thinking about managing pressure, friction, and shear everywhere, all the time for all of your clients. So thank you. Hopefully that was a helpful quick overview and left you with some tools and some things to think about. I want to open it up for questions. I do see a comment here from Mercy is that pressure surfaces tend not to help much with high-risk areas like heels. You're absolutely correct, Mercy. And in fact, the product picker suggests that you look at the management of heels independent of the support surface and do something different. So whether it's heel boots or supporting the heels with pillows, any of those things will be effective depending on your individual patient.
Okay, Linda, thanks. I think people need to realize that having a rehab involved in your interprofessional teams becomes a very important element to patients getting better. And both the cases today, Linda, will have similar features. I know we were talking a little bit earlier, but let's start with case 130. And Carol, why don't you come on, introduce yourself? And yes, I have added some interactive questions to your discussion.
Can you hear me?
I can.
Okay.
You're
My
front and
name is
center.
okay. My name is Carol Liu. I am a nurse practitioner, also in SWAC, work at the Seniors Health Center in North York General. And then I take care of the resident with wounds, also with other medical issues, Today I want to present as a case happening in the long-term care here. And I was just hired last year, but since I came here, I found a resident wound, a stage 4 pressure injury. Do you mind to go to the next slide now? Okay. The question for the audience is, do you think the wound is healable or maintenance? What dressing do you suggest to improve this resident stage 4 coccyx ulcer? Like the improve what like the antibacterial or any dressing? Thank you. This the wound has been there for over 4 years, and then because maybe the app changes, I only got the earliest picture is the June 17 last year, 2025. you can see the size and compared to the recent two size. The depth after I using the back dressing slightly decrease, and the size wise maybe smaller, but because of the picture taking a little bit, sometimes they take far, sometimes they not close, a little bit, not much difference in measurement. Thank you. The case is she is age is 70 to 79, female. Her height is 165 centimeter, weight around 64, BMI 23. Her ethnicity is Asian. Previous occupation is a restaurant owner. She is widowed. Her husband passed away during COVID. And geography is in the city. She has allergy to sulfamethoxyl and trimethoprim, and no substance use. Her past medical history is stroke with left side hemiplegia and AFib, also dementia, diabetic. Her recent HbA1c is 8.0. I believe it's last year. Not the recent one. And also she has a CVD, hypertension, DVT, depressive episodes, dyslipidemia. Her wound history is, as I mentioned earlier, and the resident has had this stage 4 coccyx wound for over 4 years. In July 2021, she got infected by COVID, and then she developed complication from it, including stroke, multiple pneumonia, DVT. She was in ICU for a period of time. There were she was in the hospital for over quite a few months. Even she transferred to the other hospital because of the North York General was quite busy at the time. Anyway, at the end she became stable and discharged to the this long-term care in November 2021. Her stage 4 pressure injury at her coccyx has been stable, but not much improving, even though different dressing was provided. Nutritional wise, she's eating okay, and then her appetite good. History of osteomyelitis in 2021, when she was in the hospital, you treated the IV antibiotics. Can you go to next slide?
So I'll do the medication.
Yeah. Okay.
So medication-wise, she's on acetaminophen, which is for nociceptive pain. She's on 1 gram TID, which would be the upper limit of a daily intake. She's on cefadroxil, 500 milligrams twice a day for 10 days. And at that time, it looked like she had more symptoms of a wound infection. She's on atorvastatin, 20 milligrams at night. She's on Pixaban, 5 milligrams for the atrial fibrillation, which this is a blood thinner. And then the metoprolol would also go along with that to rate control her to try to decrease her risk of stroke. For her diabetes, she is on a combination of long-acting and short-acting insulin. So the glargine would be the long-acting insulin, and she gets that at night. And then she gets some rapid insulin for breakfast, and then on a sliding scale at lunch there. She's on mirtazapine, 30 milligrams at night. For this dose, it would help more so with the depression. Mirtazapine is kind of one of these medications that the lower the dose you go, actually, the more sleep benefits you get from it. So if you were using it mainly for sleep, it would be more likely to be a 7.5 milligram to 15 milligram dose. She's on a multivitamin. She's on zinc, likely for the wound, I'm presuming, and then beta protein as well. So this is a nutritional supplement that essentially it's a protein powder that you could put into foods and such. Next slide. And then I'll hand this back to you.
Okay. Thank you. Yeah, no lost weight within the past 6 months, and also when I look at the weight, slight increase, and has been eating well, and then not a decreased appetite either. Okay.
I'll do the
handle
labs as well. Yeah,
Yeah.
just to be consistent. So her creatinine is 26. Given that she's like not very mobile, I suggest this is probably low due to kind of loss of muscle mass. And her hemoglobin is 117. Her white blood cell counts, and more specifically, her neutrophils were normal in December there. And then this wound culture, which I think matches with the dates that you guys felt her wound was deteriorating, grew Staph aureus and was sensitive to the cefazolin. Next slide. Dale?
Thank you. Yeah, so on this slide, we can see a common organism that we see, of course, associated with skin and soft tissue infections with Staph aureus. So the fortunate thing is that here what we're looking at is MSSA, so methicillin-sensitive Staph aureus, so not MRSA. So it's the more susceptible version of this, which is very well treated by the cefadroxil that the patient is currently on. So that's nice to see. That said, the interesting thing is that in the note about the clinical examination piece is that there was an odor. And the reason why I highlight that is that oftentimes anaerobic organisms don't culture very well. And so we wouldn't rely on a swab or a culture to be able to establish whether there's also an anaerobic organism in the area. But we can see Staph aureus here, MSSA, that's quite nicely susceptible to cefadroxil that the patient is currently on. And I'll hand it back to you guys.
Okay, let's vote on this. Do you think this is, from what you've heard so far, healable, maintenance, or non-healable? And let's put the vote up. May heal, but needs an interprofessional assessment. Okay. And so the majority say maintenance, 48, 11% healable, 10% non-healable, and may heal but needs interprofessional assessment, 32. So that would almost take us up to a tie with healable and maintenance. And but let's see the rest of the story. This is 4 years and hasn't gone anywhere. I did put in, Dale, what we knew from the history here and the course of hydroxyl, but apparently the odor has disappeared. Is that correct?
Yeah, that's correct.
Oh, that's
After
good.
antibiotic.
Yeah, that's good. It's interesting because oftentimes when things are really malodorous, like when there is quite a lot of an odor associated with a wound, um, I mean, we would say that it's an anaerobe that's causing that most frequently. But at the same time, other organisms also have a smell, as particularly Staph aureus does. But it isn't particularly putrid or anything like that, so it's not overwhelming and tends not to be documented that much. That said, when you're doing just through the regular course of wound care, if you're packing the wound, if you're doing a little bit of gentle debridement, and even the cleaning and that sort of thing, is going to debride away some of that tissue that would carry that anaerobic infection and will also expose that area to oxygen, which of course will also kill the anaerobes. So it's interesting because it wouldn't have been the antibiotic that would have necessarily killed the anaerobes that are in the area if that's what was causing the smell, but it would have been the regular wound care itself. But what we can see here is that on the NERDS criteria on the left-hand side, we do fulfill superficial or infection signs.
Daryl, wait,
Yeah.
just wait a second. Go to the next slide.
Oh, okay. Oh, sorry. Do you want me to ask the question? Do we think that this wound is superficially infected or a covert infection? Do we think that there's a deeper surrounding infection in this area? Do we think both options 1 and 2? Or do we think that the wound is not infected at all?
It's interesting though, but sometimes the odor can come from gram-negative, say, and sometimes they're superficial, and what you said about clearing them may help as well.
Yeah, it can, and often the gram negatives are also what are the anaerobes itself. And I mean, when we think about gram negatives in anaerobic organisms, we think about coliforms and organisms that are commonly associated with the gastrointestinal flora, and of course, those smell. And so it's not surprising, but it is a little bit of a different odor depending on the organism itself. Of course, Staph aureus smells different from Pseudomonas, which smells different from many other organisms. Hope none of you are eating.
Let's see the answers. And it looks like the majority of people think that both are involved. And I think there was some degree of infection there at one stage. Let's go on to the next slide. Okay, go ahead.
Okay. The resident is on air mattress and alternating floating and the pressure, and also reposition with wedges every 2 to 4 hours. Wheelchair. When she gets up, she is on Raho cushions. She does get up 3 times weekly in the morning and putting back to bed after lunch. Um, on getting updates, and then like the other 4 days, she stay on bed. She complain about the when she gets up, or she more tired if she stay the whole day long. That's the reason. Like the after lunch, she back to bed.
Okay, Linda, this question was put in after you and I talked. Let's see this.
I'll be interested to see the answers. I'll leave it to you, Andrew, to share when we have enough votes because I can't see them voting just yet.
That's on purpose. I can't either. With your talk, I could.
This is where you need to have like the Jeopardy music or something going on.
Yeah.
Okay, alternating air mattress. Well, we don't have any evidence that alternating air is better than some of the other mattresses that are out there. I'd want to be thinking about any potential risks that that may have. So if there's a transfer border on it, I'm less worried. Even when clients aren't moving around a lot, there can still be issues. But if that's all you have, then that would be fine. I wouldn't necessarily do a 6-inch foam mattress. I mean, they do have a pressure injury, and I'm assuming that they're lying on it at some periods of time. You could also do a non-powered air overlay. Again, no evidence that one is better than the other, but you just also need to be worried about a risk of entrapment. So there's more than one answer that could be appropriate for that individual.
If you
Depending on the
saw
hospital
that patient
situation.
now, would you use the foam and gel?
If they can be positioned off the wound or are not spending a lot of time off the wound or on the wound, I might consider that. You can also cheat and do a foam mattress, but that has air cells under the coccyx, and that's probably what I would end up doing for this client, simply because it gives you the best of the both worlds. It gives you the most immersion and envelopment in shear management. And if you're sitting the client up in bed, it still helps to manage pressure, friction, and shear in those areas. So that's what I would probably personally do.
Okay, thank you. Let's go on to the next one. Go ahead.
The pain is when do the dressing change, you cleans the with the, the wash soak the gauze. She complain about pain. Otherwise, she's okay, not in pain. Yeah, family. She has 2 daughters, 1 son. 2 daughters are very supportive and visit her 3 times weekly and bring homemade food pureed. Also, she's on wheelchair and bed bound. If that's the alternate. Uh, yes, other factors immobile depend on staff for repositioning. Yeah, thank you. The next slide, please. Only information is coccyx and length and the width about 1 centimeter. The depth is concerning 2 point. It was 3.3 centimeter. Right now, it's 2.5. And duration is over like the 4 years. November 2021, she came with stage 4. And currently, because of the active back dressing was quite expensive, so the rep like the recommend use the Prevna back dressing. And this one is a 14 days machine can last 14 days. After that, is disposed and have to use another one. This cheaper. And then like for the wound bed, I still want like antibacterial dressing on. That's I use the Acticoat that can put under the vac dressing. And then because of it's quite deep, we use the pier and the place cover dressing for vac. And then because the wound is quite still deep, and I put the extra slim the black foam to the wound bed so can suck better. Yes, that's the back dressing. Peri wound, we know erythema and edema, but scar tissue, but we're still using the advanced Kevlar spray to prevent those issues. Wound debridement never done, and since because of the visual, like the cannot visually see there any like the soft tissue, but definitely maybe has some biofilm there. Moisture balance wise is okay. I would say adequate. Thank you. Can you go to the
Okay,
next
so
one?
when you just you put the back on her leg so that it wasn't interfering with her positioning, and you just had the dressing with an extension. Let's vote on the back, and then Dale, we're going to put up local wound care. Okay. Is negative pressure wound therapy indicated? And you will have seen this slide last week as well. I'm going to be interested in this vote. And Karen, I'll probably go to you and Jolene. Okay, Karen and Jolene, help me out.
So we agreed with 46% of you, and we said it's likely a maintenance wound and it's not indicated.
And what if the cause is corrected and other modifiable parameters assessed? I think one of the things that was keen to me, and if it was a healable wound installed, but Carol, there was very little exudate coming out of the back. Is that true?
Yeah.
Yeah.
Should I see like the because coccyx wound and connector cannot directly connect to there, and then has to use the bridging and to the bridging the like connector putting in the bridging, and then when last time the back dressing change was there are some of serosanguineous exudate. I would say a few days there are maybe 20 to 30 cc, but this time there's none of them, only partial of the bridging wet. There's nothing on the tubing.
Okay, let's
Yeah.
go
The
on to
original
the
one.
next one.
I think Jolene was going to make a comment.
Jolene, do you
Oh.
want to make a comment?
Well, there's not a lot of good evidence that supports negative pressure wound therapy in pressure injuries. And the only time that I've really seen it work well is when the person has been taken to the OR and the pressure injury is completely debrided, so it's an acute wound. And then they place the vac dressing right on in the OR and treat it more as an acute wound as opposed to a chronic wound. That's the only time I've really seen it effective. The downside to that is that they cannot put any pressure on their wound whatsoever after that. So they're on bed rest while they have the negative pressure wound therapy, which also isn't ideal.
Yeah, and it's kind of interesting. We were part of 2 random controlled trials for pressure injuries, and that was with KCI. And I tried to get my hands on that data, but it never saw the light of day because it did not work. Let's go on to the next one. And Dale, you can comment on this. Andrew, that's the old one.
No, change the other one,
Huh?
the case.
Oh, okay, fair enough. All right, got it. Listen, it's in the next case, so let's vote on this one. Very good. You're on top of it. I'm not. And Linda's put up the session evaluation. And oh, Dale, look at that.
It sounds like people have been listening to me rant. But the interesting thing in this case is that there's a number of good options. Like realistically, the infection that we're dealing with here, it's MSSA, and we know that AMD gauze, which contains PHMB, is actually a fairly good agent to use against MSSA as well. So, although I'm thrilled, of course, that people want to use betadine soaked ribbon gauze, which I think I would probably use in this case too, given that there's packing involved, um, it isn't always something that we can use. So I do want to kind of hedge my bets on all of these all the time. Like we can't use iodine all the time. Um, Hypochlorous acid soaked gauze as well. I mean, and then acetic acid as well. Acidifying the area as well is going to be helpful, but that's just because it's a less tolerable environment for the bacteria to grow in. It's not actually going to kill the bacteria necessarily, right? And so just keep that in mind as well. But yeah, no, I'm happy with some betadine soaked ribbon here.
Yeah,
What do you
just
think, Dr. Sibbald?
remember the AMD gauze, the AMD, the antimicrobial dressing, what that stands for, but polyhexylmethylene biguanide is a derivative of chlorhexidine, but it stays in the gauze, so it's not really going to get to your superficial compartment. And so that's one thing to consider, whereas the others will to some extent. But I think the betadine gives you the best antibacterial action. So I agree with Dale on that. Next one.
Dr. Sibbald, sorry, I just wanted to add a little piece to that talk about the packing, because sort of my thoughts, I picked the AMD specifically just because I was under the impression that the wound wasn't draining a ton, and that they were trying to keep the frequency of the dressing changed to maybe a couple of days between dressing changes. Betadine soaked ribbon gauze would technically require a daily dressing. I'm just curious if that's feasible for where they're at, or maybe could that be reduced?
I think the thing that would bother me about the PHMB gauze is that nothing is going into the surface wound compartment. Whatever you compress the wound with is going to be gone within, a few hours. It's not going to last even a day. That's
Jeremy,
what would bother me with that.
yeah, with respect to the changing of the dressings every day, I agree. I think ideally they would be changed every day, but it's also a reflection of how much drainage there is. So if it isn't draining a heck of a lot, that would add some questions about the need for the provider and so cause and things like that. But if we are wringing it out nicely, if it's not draining too much, and when we're taking it out, we aren't noticing that it's been kind of that the color has all been taken out of it, for example, then I'm comfortable with extending the treatment times or the dressing changes if that's not possible. But you're very right. In an ideal world, daily dressings with iodine is what's recommended and what I would usually use.
All right, let's go on to the next slide. Go ahead.
The management team is NSWAC, registered dietitian, a physiotherapist, and MRP. Also, me as a nurse practitioner also involved there too. Any other suggestion?
Next slide. Yeah. Okay. I think that probably unless, you got a new direction, I would call this a maintenance wound. And
Okay.
we just had the discussions on the dressing, but Karen and Jolene, anything that you'd like to add? And then Linda, anything you'd like to add?
Yeah, I think you mentioned that you think there's some biofilm there, and as you know, we can't see biofilm. So I think that's why I would like the iodine dressing. It really is the only dressing that is known to penetrate biofilm. I think that the other thing you can look at is the IWII, the Institute for Wound Infection. They have in that chart that Dr. Kalina Samji showed last week, they have a step up, step down approach for biofilm. So you might look at that, and that, but it would be povidone iodine would be recommended. So, and not the negative pressure wound therapy. Jolene, do you have any?
I don't have anything to add. Nope.
Would Inodine be a better option, Dr. Sibbald, to get a
Hold
longer?
that thought, and we'll go on to the next case.
All right.
Then you and I will have that discussion.
Okay.
Okay.
Go on.
All right. Now, and I think, concentrating in this patient on quality of life and trying to give this person the best possible journey, to me would be paramount here, rather than, worrying about the wound to heal or a negative pressure wound therapy. Sometimes when wounds are present for that long, but I don't see any evidence. And if you get a hyperkeratotic area or an area that thickens, you need to biopsy it to rule out a squamous cell or malignancy. But I think in this case, it looks pretty straightforward, and perhaps the patient is protein deficient and granulation tissue is protein. Linda, your comment on that?
I was just going to say that you read my mind thinking about quality of life being the paramount thing for this client, and certainly looking at, can we make sure that she's comfortable? She's up 3 times weekly in the morning. Is she only up 3 times weekly because of resourcing, or that's her family's choice? And what's she doing? Can we, make sure she's got stimulation and engagement and those sorts of things to really focus on that quality of life aspect.
There long enough, and I think Karen said that I think we all kind of come from that same feeling, and there is a certain percentage of wounds that we're not going to heal, and even if you optimized everything and healed her, you'd probably have a hard time keeping it healed. And I think focusing away from the wound and onto the patient might be a very good move here. But, it's very, very difficult. And sometimes, Karen, you brought up last time that discussing this with the family and coming up with a realistic approach. But it sounds like the family is quite committed here.
Yeah, I would echo Linda's comments there, Dr. Norton's comments, because the scenario, her creatinine is quite low. There's low muscle mass. She's probably got some sarcopenia. They're trying to replace her protein. She gets tired. She's only up 3 mornings a week, and otherwise she's tired. So I really think that a good conversation, and Dr. Zhao may have some conversation guides that might be helpful here. A conversation with the patient and family would be helpful.
So why don't you comment? You do see this kind of patient, I know that.
I do. So we do have conversations, especially if there's been a change of status, or we're kind of trying to discuss the fact that, this wound is not really going to go away in any short period of time, and changing that focus from healing everything and fixing everything to quality of life is important. There are some conversation guides like how to discuss having kind of a serious illness, etc., that might be helpful. Starting to talk about things like palliative care, not in the sense that I think she is dying in the next few days, like she's not actively dying, but starting to move that ball in terms of curative approaches to perhaps more comfort care measures. I find that sometimes a lot of families take, when you start talking about palliative care, it means you're going to give up on their family member. So making sure that that's not the approach that you're taking, and having someone who the family trusts to have that conversation with them, I find is helpful, rather than try to have that in the ER setting, or have it all of a sudden when the patient's really, really sick. Like I find that the families find that very hard to take at that point. So when she is stable is the time to kind of start having these conversations, and to almost give them like a heads up of this is the natural trajectory of someone with this many comorbidities is important.
Okay, thank you. And hopefully we've got enough, Carol, that this is going to help you going forward with this patient.
Great. Thank you very much for your expert opinion.
Okay, you are welcome. Let's go on, and thank you for presenting to case 131. And Helen, you are front and center.
Hi, everybody. Thank you for doing this weekly for us. So my name's Helen, and I'm here with my coworker, Catherine. We're from Norview Lodge in Simcoe, Ontario. Next slide, please. So we're going to focus on 3 key questions. The first being what the best treatment options for managing the deep coccyx pressure injury would be. And the second one, how can we better manage pressure, moisture, and infection risk? And the third being, what would the care include if the patient were to become end of life? Next picture, please. A slide, please. Okay, this was taken on May 7th, 2026. It is a large pressure injury located on the coccyx, caused by prolonged pressure and moisture and friction. There is some granulation tissue around there, which indicates some healing, but I don't think it's going to heal, and areas of slough as well surrounding the maceration.
Next slide.
Next slide, Catherine.
So case synopsis, our resident is a 60 to 69-year-old female. She's suffered with obesity at 128.4 kilograms. She's 168 centimeters tall. She's Canadian, retired, and single. She does have a rather supportive family that does come in and visit. She lives currently in a rural long-term care home in southern Ontario. She doesn't have a history of substance abuse, and she has no allergies. She's got a medical history of depression, type 2 diabetes that's managed with both long-term and short-term insulins. And she's got hypertension, which is monitored daily, dyslipidemia, renal disease, and a history of necrotizing fasciitis, which was part of this wound. She has a deep coccyx pressure injury. It's been difficult to heal due to multiple comorbidities, and she's got some significant mobility limitations due to her weight and other limitations. She's got a catheter, an indwelling catheter as well. And despite current treatments, there's ongoing concerns with her with pressure redistribution with this resident. She does have a wheelchair. She does get up into that wheelchair occasionally, but obviously she's at risk for deeper infection and continued further wound deterioration. Next slide, please.
Okay, so medication-wise, as you had mentioned, she is on long and short-acting insulin. She's also on semaglutide. Semaglutide is a GLP-1 agonist. It is sold under certain trade names that you might recognize better, such as Ozempic or Wegovy. She's on pain medications. Hydromorph-Contin is the 6 milligram capsule in the morning there and 3 milligrams at night. We typically give those 12 hours apart, and it's supposed to be a slow release formulation of that. She's also on hydromorphone immediate release, 2 milligrams at noon and 1 milligrams every 4 hours as needed. I expect hydromorphone orally to kind of kick in about half an hour into after you take it. So if you are trying to use it to time for dressing changes, just to keep some of those timelines in mind, hydromorphone sub-Q will come on faster, so that's given by injection. It's 0.5 milligrams. Anything that you are going to inject into the patient essentially doubles as the oral, so this would be equivalent to 1 milligram orally prior to adjusting changes. Gabapentin is for neuropathic pain. She's taking 200 milligrams 3 times a day. That would be a total of 600 milligrams, which is on the lower end, depending on how frail she is and how many side effects she has, so that there is some room to move up there if needed. Duloxetine is it's an antidepressant. We do use that for mood. We also use that for neuropathic pain, and she's at 30 milligrams a day. 60 milligrams would be the maximum dose for duloxetine. She's on metoprolol, which is a beta blocker, so that will lower her blood pressure as well as slow down her heart rate a little bit. She's on rosuvastatin, 20 milligrams at night. And there must be a typo here because it's not used for groin irritation and it would not be used PRN. Is that just me who sees that, or? Okay. Moving on. So she's on famotidine.
Yeah, I'm not sure why that's there.
Okay, good. I was like, oh, maybe I'm missing a drug.
I think that's meant to go with the hydrocortisone.
It's with the clotrimazole.
Oh, okay. That would make
Yeah,
more sense.
that makes more sense.
So she's on the famotidine. Famotidine is a H2 blocker. So this is used for acid reflux. She's on Docosate, which is a stool softener. Vitamin D3, she's on 4,000 international units a day, so that's a slightly higher dose. I'm assuming she is low on vitamin D. She's on ferrous fumarate, which is an iron medication. She takes it every 3 days. We used to prescribe it every day, and then they found that every other day, if you're taking it correctly, seems to be just as good. So every 3 days would be slightly below that. Magnesium glycinate, people use that for sleep, sometimes for anxiety, sometimes also for constipation. She's on a multivitamin as well. So she's on multiple creams here. Oh, you guys fixed it on the go. Look at that. Clotrimazole, PRN for any kind of fungal rashes that they may have. Fluticasone spray. Looks like you're using that PRN for around the stoma in case there was any dermatitis or something going on there. And then hydrocortisone 1% cream as needed for groin irritation. Sometimes if you want a non-medicated cream, sometimes the zinc oxides as a barrier would also be helpful if it's more just a contact irritant dermatitis. Next slide. Okay, turn it back to you.
So there's been no significant weight loss in the last 6 months. There has been the past, but not recently in the last 6 months, and she's not really been eating any less than usual for the last 7 days or in the recent history. Next slide.
Okay, this is a UA and a microscopy and a culture. So it looks like she was having some blood and leukocytes in her urine. The culture did come out mixed. To be honest, I would probably be tempted to repeat this. She would need at least a repeat of her microscopy here. If she does have ongoing essentially red blood cells in her urine without any good reason, a reason being infection, stones, etc., like some other reason. If she was well and within her goals of care, she might need additional workup for that. Although with that many white blood cells, I don't know. Dale, what do you think?
Yeah, and maybe just to add to that is that even if we'd seen some bacteria that came out of this rather than just the mixed growths of doubtful significance, I would suggest that this would be asymptomatic bacteriuria unless she's experiencing dysuria, increased urinary frequency, or suprapubic tenderness.
Right. And as Laura Castles just indicated, this is ongoing. This just never stops, right? This bleeding.
The bleed, yeah. So bleeding isn't a symptom of cystitis, traditionally, and so it really does need to be one of those three symptoms: the dysuria, the increased urinary frequency, or the suprapubic tenderness. That would lead us to use this to be indicative of cystitis or pyelonephritis, for example. Otherwise, it would be indicative of asymptomatic bacteriuria, which does not need treatment with antibiotic therapy, unless the patient is having a baby, or if the patient, like if they're pregnant, or if the patient is having some instrumentation of their urethra or their bladder, for example.
Did this patient have an indwelling cath? Did I?
She did have one, and she does not have it right
Anymore.
now.
Okay. So for if this is not an infectious cause, like I said, if it was within her goals of care, if I had an outpatient that was having kind of persistent hematuria, the next step of workup would actually be imaging in terms of upper tract and lower tract imaging, and then plus or minus referral to urology for a cystoscopy would be the workup for microscopic hematuria that was persistent.
Can I just ask another question about the catheter? Sorry, just from an NSWAP perspective, like a continence perspective. I know that was one of the questions that you had, was about the urinary incontinence. What was the reason for catheterization and then discontinuing it? Was it just for urinary diversion?
Comfort and urinary diversion. Our NP is online too, and she's answering some questions in the chat as well. So I'm interested to hear what she has to say about that.
It just kept the moisture away from that.
Yeah, it really
wound.
diverting the moisture away from the wound.
Right.
There was such difficulty managing the dressings with all of the moisture and stuff.
And was it effective, or were you still getting leaking?
No, it was effective, but she had a lot of irritation and the bleeding, and she was hurting, and that's one of the reasons she demanded it come out. So she just it was just too irritating.
It was uncomfortable for her, and this ongoing complications and infection, that was just an ongoing thing with her. Okay, next slide. Pulses are available there, and there's no compression. This wound has been ongoing since mostly her admission, and we don't have a quiz here, so I'm going that it's a non-healable wound. We've assigned it as a non-healable wound. And that's what we're asking. We're assuming that you would agree with that. The only thing that I would add to these standards is that the exudate with this wound is increased, and we changed the dressing far more, probably more daily, so that NERD's qualification, then the non-healing, but I would also add the exudate to that as well on both of those slides. You can go to the next slide. So she's a total assist. She is on an air mattress. She uses a regular transfer chair on bath days to get herself to and from the shower and the bathroom with PSW assistance. And she's up for lunch on occasion in that chair, but she doesn't sit for very long. She's uncomfortable sitting and she refuses to be out of bed for most of the time. Next slide. So she's in pain all the time on pain ad assessments. She's usually saying a 9 out of 10. She's got a support system. Family members and friends are in all the time. Nursing staff, we have RNs, RPNs, and PSWs on staff on the floor, and we have our physician and nurse practitioner. Our nurse practitioner's on the chat right now, and our physician is fairly involved. We have NLOT and wound care team both on staff, and a wound care nurse that does her best. We have dietitians involved, and physiotherapy and occupational therapy have both been involved with this resident. Her mobility is limited. She requires repositioning Q2 hours, if not more often. She does try and do her best herself, but her size limits her ability to move herself. She is incontinent, and she's on a sort of a toileting routine, changing routine. She has continent bowel. She is on an ostomy, but that does get changed probably daily, if not every other day. Patient declines to get out of bed. She doesn't tolerate turning or repositioning. We prop her as much as we can with pillows and turn her as much as we can and reposition her as much as we can with her within her allowances. She's got multiple. Go ahead. Sorry, she's got multiple comorbidities, including diabetes, hypotension, hypertension, urinary tract infections, other skin issues, and then the prolonged pressure on various areas of her skin and of her body, just because she does refuse or decline to get out of bed. You can go to the next slide, please. So the wound's obviously located in her coccyx. It's 10.5 centimeters currently by 6, with a depth of 3 centimeters at its deepest. It's been ongoing 3+ years. Current dressing is a Q3 day, but realistically we're changing it every day, if not more frequently than that. Sometimes it's Q shift. It's a pure cleanse soaked gauze to the wound bed, which we allow to soak for 5 minutes, or as the patient tolerates. We then remove and dry the area as we can and apply Inadine gauze, conforming dressings to fill the cavity of the wound. We're then dressing that and filling the wound bed with gauze and a Mesorb pad to try to reduce the amount of pressure with a flat dressing, and then using Tegaderm on her skin, and we're spraying using Skin Protect to her skin every day. There is a note to not change the Inadine daily, only when it changes color to that white color, but her tolerance and pain level and the exudate in the wound is just requiring that dose dressing is being changed daily, and so that order is it's being changed daily. Previously she's had a vac, very little response or change to the wound with that vac. The peri-wound is fragile, it's macerated, it's a little inflamed, somewhat edematous. It has been debrided surgically previously, and although a moisture balance there says it's adequate, I'm unsure about that. I would appreciate other opinions in that. Next slide. I'm guessing this is a question for everybody.
Yeah, let's just get people's opinion on what the best treatment or options are on this. And then Linda, you can comment because they are having trouble carrying through some of these things.
That's great. I've been writing sticky notes of things to ask.
Yeah, that's what I figured.
My response was all of the above.
Well, let's see. I think you're in good company. Linda, some of that wasn't possible though. So Andrew, let's see it. Yeah, your response was pretty good. Linda, how did they do all of the above?
Well, I have a couple of questions. The first thing is, her refusal to get up. I'm wondering if that is she's not getting up because she doesn't have a comfortable wheelchair that works for her, or if somebody is on bed rest, one of the side effects is learned helplessness and depression. So you get the learned helplessness and depression, don't want to get up, and the not getting up causes the depression and learned helplessness. Like you've got this um, circle of doom going on.
She would just prefer, yeah, to be in a room, her meals brought to a room, does not like to be repositioned, claims that she doesn't need to be repositioned. She's a tough case, and we're trying so hard to help her.
Mood and apathy are definitely components.
Yeah.
Yeah, and I would look at that. I mean, often, it's hard to get people out of that cycle sometimes around, um, the impacts of, being on bed rest and getting up into, a chair that isn't comfortable is part of that. One of the things to think about, just thinking about her size and her body shape, does she have like a posterior gluteal fold? Do you know what I mean? Like her back comes down and her butt comes out and then around. Is that an issue? Okay, so if you think about that, if her bum is back in the chair, her back actually isn't supported, right? Because you can't get back far enough. So it would be quite uncomfortable. And there may be ways of getting like a rental chair or a chair on loan that's a bit better set up that might give her a bit of a positive experience. And if you can catch her in something that, she's getting up for her shower, for example, but if you can catch her in an activity that engages her, that she's interested in, or there's a visitor or something, you may be able to distract her long enough to get her sitting for a little bit that then creates a positive experience to try and get that what I call the circle of doom, but I don't really mean that, but that sort of vicious circle you're in to start to move the other way, that you might see a little bit of brightening there. And then to think about in terms of repositioning, there are some repositioning systems that can be left under larger clients, so that you can have an easier time with turning and repositioning. But it gets really hard when you have somebody who doesn't want to be repositioned, and that.
But I think
but
that
it's
was part of the
worthwhile trying.
problem with the back dressing too. She wasn't sitting right for it, and it just wouldn't do its job. That was a big problem.
Yeah, and that can be an issue too. And I'll defer to the dressing choice to sort of outside of my scope of practice as an OT. But one of the things that I might be advocating for is if the vac dressing is appropriate, can you bridge that dressing so that the tubing comes away from a sitting surface so that it's a bit easier when she's up in the chair, or consider whether or not that's the right approach for her. But often if you can bridge that tubing along to someplace else, it just makes it a little bit more functionally approachable.
You.
I think the tubing was put in I'm trying to remember, it's been a while, but the tubing was put in a position that it wouldn't have irritated her.
Yeah.
I'm sure it was.
Yeah, it's worthwhile just thinking about. I'm sure that you did that,
But it
but
was hard, right? She doesn't have the catheter, trying to get it to suction properly where the wound is, and you'd get it, and then it might get a little wet, and it would loosen. It was really tricky, right where it sat.
Yeah.
The vac was always a complicated tool to try to use, and also, it with the changes with it as well. The some of the nurses understand vacs better than others, and some it's like a bit of a puzzle. And if you don't get that seal right, the vacuum isn't necessarily as effective as it is other times. So, looking for something a little bit more, something that might be a bit of a simpler dressing that will manage the exudate. That nurses in long-term care that are overwhelmed, and we're trying to do these dressings can manage on a Q shift, or even if we can decrease that dressing change a little bit to a daily or a Q other day, every other day, if it's possible for this resident, as even the moving her is painful and uncomfortable and causes her such issues, right? Which is why one of the questions was looking at transitioning to an end of life care for her. What are we looking at as far as what would be best practice and best comfort measures for her with this wound? Because as her care is sort of transitioning in that direction, I think discussions are heading in that direction to some degree
I
for
just
this.
want to emphasize something that you said. I mean, Jolene talked about, lack of evidence for negative pressure wound therapy for um, pressure injuries. But what you said is also incredibly important around staff's familiarity with the dressing and ease of use and all of those sorts of things. Like that's definitely going to be something that gets considered, whether it's negative pressure wound therapy or mattresses that have a lot of bells and whistles or equipment
Right.
or all that kind of stuff. The right device is what works for the patient, but also what staff can handle. And I think you brought up a really important point.
Go on to the next one. And what would you use for local wound care? All right. I think that is a very interesting vote. And in looking at this, it looks like the surface of the wound is mostly open. Is that true?
It is.
Yes.
Yeah. So sometimes if you take a piece of inidine and you fold it and you cut slits in one piece, you can put a second piece on top of it. And
Okay.
what that can do is give you a longer time before you need to change the inidine. And then maybe, put Cavalon or no sting around the outside to prevent the maceration and put a super absorbent over top of it, or even betadine soaked ribbon gauze. But I mean, I agree with 80% of you. Dale, do you want to comment?
Yeah, I mean, the only thing that I would say here though is that the major driver of this isn't infection. So
Yeah.
focusing on decreasing the maceration, decreasing the drainage and that sort of thing, I think is important. I'm on board with using inidine, particularly when we're using a super absorbent and that sort of thing. But do I think that this is 100% necessary? Not necessarily.
Yep. Yep. Okay. And the pain, I think Zhao did make a comment that you certainly could gradually go up on the pain medication to help us too. Let's go on just so that we do finish.
So the management team includes our nurse practitioner who's been on the chat today, our NLOT team that works with our whole home, our wound care nurses, our registered staff, and we also have dietitians and our physician on board as well.
Next one. What are the best treatments? I think we've discussed how can we better manage pressure, moisture, and infection risk. I think part of this is maybe going back to quality of life here again and trying to get that pain level down to a 3 or a 4. And what would the care include if the patient were to become end of life? Zhao, you're probably best at answering that.
I don't know that there was enough on the presentation to actually do an accurate pain assessment,
Yeah.
because it doesn't sound like it's coming fully from the wound. It sounds like there's other things kind of happening and in play there. So it depends on kind of what she's in pain from. And then as Linda mentioned, like, is she using the pain more as an excuse because he doesn't want to participate and do things, rather than her being actually at a 9 out of 10 the whole time? if I'm just going to bring this up here because I've had a few patients selected as well. Like, if she is transitioning to kind of end of life care as well. Some of my patients with similar types of things had elected for MAID in the past as well, which may or may not be an option, depending again on very specific. I wouldn't necessarily offer that up as an option, but I've also had people in my facility decline to even listen to the patient when they
Yeah,
have
she
brought
would
it up as an
decline. She would
option.
decline this for sure.
Okay, that's perfectly fair. Like I said, it's just on the other side. I've had
Right.
it's requested and then the provider refused to listen to
Right.
that request, which is also, I don't think, appropriate. But figuring out kind of exactly what's limiting her and if pain truly is the answer, or if it's, like Linda said, kind of a combination of other things that's making her kind of given up a little bit on the participation end.
Okay, let's go to Queens, and I think you have your hands up there.
Yeah, I do. Thank you for bringing this case. I can tell that there's a lot of compassion being displayed here in this challenging case. One thing that I'd like to go back to, in addition to everything that's been said, is I'm not sure why she's incontinent, whether it's a mobility issue or whether sometimes with diabetes you can get overflow incontinence. And whether I think because of the ongoing hematuria, I think it's important to talk to her about what that might mean. I think some other bladder investigations, and possibly if she was interested, having urology involved in whether we can alter the degree of incontinence, or someone mentioned in the chat the wicking catheter, the female external catheter, but cost is an issue. So,
and I think she's declined the urology, given other health concerns as well. Laura is saying, so she has been given that that option. Yeah. Oh, the urologist declined her. Sorry. Yes.
You have access to bedside ultrasound to get a post-void residual on her?
Mm-hmm. Yes.
Just wondering if she's got a large bladder there, whether that's contributing to some of her pain. If she's got a voiding dysfunction because of her diabetes, that can be quite painful. And whether there's some upper tract changes. I don't know if that conversation, obviously, if you've talked about urology, seeing her, you've gone down that road, but there may be some intervention that might be helpful.
I was kind of thinking the same thing, not to interrupt, but I was thinking more along like nutritionally, maybe there's something that's irritating her bladder, causing some overstimulation that could be triggering similar symptoms. And if she's having like urgency and she has mobility issues, she can't get to the toilet in time, or she doesn't get help. Sometimes toileting schedules and those types of things can be really helpful, but hard to implement. Yeah. Sounds like maybe psychology or psychiatry could be of service, and if maybe there's something to improve her mood. Obviously the pain, like a lot of this stuff can be tied together, and maybe you start to see improvement in multiple domains as some of those things start to take the pressure off her. Like, I guess that's a pun, but it was totally unintentional. I'm curious if she'd have access to eSTEM. I know I bring that up all the time, but it's not something that's always available between the resources and the expertise that's required. But that would be an adjunctive therapy that maybe would be better to trial instead of not negative pressure.
All right, we are at closing time, or almost, and we want to get you to fill out your evaluations. Are there any last thoughts from the presenters on this case? But I think there are some suggestions there that may be helpful for you.
We appreciate the thoughts and the suggestions, and thank you just so much for looking at it.
Yeah, well, thank you for presenting it. And I think that the more you participate in these sessions, the more you will get from it. And we do encourage you to send in your cases. And I think both of these cases do have a reflection around quality of life and the need to look at the whole person within the scope of what we're doing in terms of treatment here. So next week's session is, Renika?
Next week, we have a registered dietitian talking about nutrition and treating the whole patient for wound healing.
And I think the whole aspect around enough protein when it's safe for the protein to be ingested is a big thing because granulation tissue is protein. Please fill out your evaluations. Sorry about the cold weather, but apparently by next week it's going to get warm again. So we will see you next week.
No, as we did.
Did you see some snow up there? We
woke
saw
up
some
2 weeks
snow
ago.
in the Sioux. Yeah. Oh boy, don't they know it's May? All right, bye all.
Take care.